Hi, everyone. I'm Ashley Bassett.
And I'm Catherine Logan.
And welcome to Overtime with the Sports Docs. On each of these mini episodes, Catherine and I chat about a new topic or surgical technique in the field of sports medicine. We'll give you our quick take on the most recent data, ranging from operative indications, surgical approaches, post-op protocols, and most importantly, patient outcomes.
So today we have an episode that's pretty cool for you. We're going to be talking about some of the newest orthopedic technology presented at the AOSSM meeting this July. So Ashley and I were both judges for the ACE Award, which basically recognizes cutting-edge technology and innovation in the field of orthopedics, specifically sports medicine. And this is done in the exhibit hall at the annual meeting. So the winners of the ACE Award this year were MISHA, knee system by Moximed, and the Bear implant by Miach Orthopaedics. So we're going to just begin with these two and give you a little bit of overview so you know what's coming your way.
Excellent. So the MISHA knee system by Moximed, which is pictured here, is an implantable extra-articular shock absorber that is placed subcutaneously along the medial or inner aspect of the knee without violating the joint capsule. And this technology acts to reduce a portion of the weight-bearing load that is exerted on the medial knee during physical activity, thereby reducing mechanical stress imposed on the degenerative joint by about 30%.
So pretty cool. And we're obviously including a picture for you if you're watching us on YouTube. If you're on your typical audio podcast, please check us out on YouTube because we do include a lot of pictures and graphics that kind of help you understand everything we're talking through. But let's talk about why use this implant and what's the benefit. So this device is an alternative surgical treatment option for patients with mild to moderate medial knee arthritis. So this population is younger, they're more high demand, and they might not be an ideal candidate yet for a total knee replacement. So why do people use it? What's the benefit? So that's the first thing we should talk about. So the device is an alternative surgical treatment for patients with mild to moderate medial knee arthritis, so arthritis on the inside of their knee, particularly for younger or more high demand patients who might not be ideal for a total knee. So younger patients, 55 years and younger, are more prone to experience early arthroplasty failure, so having a failed total knee, with 1-year revision surgery rates estimated to be 5-fold higher than individuals older than 65 years. So therefore, the potential to delay premature arthroplasty in this cohort is pretty important.
Absolutely. So then we have to ask the question, does this really work? What does the data say? So data is still a bit limited on this because it is a new device. But there was a recent study published in June issue of Cartilage this year looking exactly at this clinical question. Can an implantable shock absorber or an ISA delay the need for arthroplasty in patients who potentially are not great candidates for it due to young age or mild arthritis? And the answer was yes. So Andres Kamal and Aaron Critch, the latter was a guest on our podcast actually at AOSSM with Dr. Latterman talking about meniscus preservation and meniscus transplant. So check that out. They found that patients with medial osteoarthritis or subchondral insufficiency fractures who underwent implantation of the Moximed MISHA knee had a 0% conversion to arthroplasty at 2 years, compared to 24% conversion to arthroplasty at 1 year and 45% conversion to arthroplasty at 2 years in a control group that did not undergo implantation of this shock absorber. So, I mean, that's pretty cool, Catherine. What do you think?
Yeah, I think these are great scientists. So we obviously have a lot of respect for these clinicians and the work that they do and the work that they did to put together this study. So I think that alone speaks a lot. But additionally, this is really just trying to fit a specific need. So oftentimes we talk about this a lot on the podcast where, studies come out and we're perfecting something that is already really good or, that we already have a solution for. This is really trying to fill a gap for these people that, okay, we have a little bit of a gap in what we can do to treat these people. And you hate to keep saying, okay, you have an injection or keep doing physical therapy, or I know this is working, but wait 10 years, so it's a difficult population. And I think they found a nice solution for it.
Yeah. I completely agree. And I think that's why this won the ACE Award this year, because even though we still have to see more longer term and randomized higher level 1 data, I think it's really exciting that it fills that gap. I'm sure you have these patients too, right? Cartilage damage too severe to undergo a cartilage transplant like an OCA or a MACI procedure, meniscus deficiency, but can't undergo a transplant because they have poor cartilage disease, but they're way too young to undergo a total knee replacement. And I think this really does bridge the gap. But I think it's important to point out that this is not, well, maybe not a long-term solution, right? So we talk about patient indications being important, and this shouldn't be sold as we're going to put this in and you may never need, an arthroplasty. This may be just a stopgap to get people to the age or the arthritis level where they can proceed with a total knee replacement without that undue risk.
Yeah, so pretty interesting. It'll be pretty cool to see how this company develops over time. But yeah,
Absolutely.
exciting stuff.
Hey there, fellow surgeons. It's Dr. Ashley Bassett
and Dr. Catherine Logan. We're thrilled to share what we think is the next frontier in orthopedics with you.
Absolutely. In our sports medicine practice, we're always looking for innovative ways to enhance our patients' recovery journey.
That's right. And that's why we're excited to talk about accelerated recovery, or XR for short. It's a perioperative recovery supplement that's been a game changer for us.
XR is surgeon formulated with clinically researched ingredients at optimal effective doses. It's designed to support wound healing, prevent muscle loss, and speed up return to functional recovery.
Totally, Ashley. And that's where XR comes in. At my clinic, we've implemented the XR nutritional optimization recommendations as part of our standard of care for patients, and the results have been really exciting.
Absolutely. I recognize that our patients' nutritional status has become an increasingly recognized risk factor for surgery. Malnourished patients face risks like delayed wound healing and infections.
Just recently, I had a high-level athlete I operated on who went through a 3-week XR recovery program. The feedback was really exciting. He had faster healing, minimal muscle loss, and overall a smoother recovery process.
And I had a similar experience. The ease of implementation and the positive impact on patient outcomes have been really motivating to continue to study.
And I tried it too. XR is a cranberry lychee drink mix. It's sugar-free and vegan, and it's safe for anyone over 12 years old.
So, fellow surgeons and healthcare providers, if you're looking to elevate your patient's recovery journey, consider XR. Let's embrace the future of targeted nutritional supplementation together.
Visit xrscience.org or xrscience.org to learn more and join us in revolutionizing perioperative care.
So moving on to our next. Yes, absolutely. I was going to say, why don't you kick it off since you speak about the Bear implant a lot. So why don't you kick us off and kind of talk about it?
Yeah, for sure. So first, full transparency. Ashley, I always try and be as transparent as possible. So Miach is a sponsor of our podcast. We did not vote on this component of the ACE awards and selected ourselves out. So they won, without any of our input. So
all on their own.
So basically, the Bear implant, I think most anybody who listens to our show more regularly has had some background of what it is. But basically, this is a new and evolving sort of treatment for ACL tears that uses a collagen-based implant with a repair of the ACL as opposed to traditional ACL reconstruction. So they were another one of the ACE awards, as we said. So Bear is bridge enhanced ACL repair. And, I think the interesting sort of aspects of Bear, and I think one of the reasons why all the judges pick them is, they've just done so much research, as far as it's not just all the stuff that we hear about at meetings now, as far as what's happening in the patient population, but really just looking back to, all the initial lab studies, the pig studies, all the animal studies, Dr. Martha Murray, I obviously have a lot of respect for as well. And she really took her time putting together something before she brought it to market. So Ashley, you want to talk a little bit more about actually what are the benefits and what is the data?
Absolutely. I think as you alluded to with our previous winner, does this fill a need? Does this fill a gap? And honestly, some surgeons out there may say, no, we have a surgery for this. We have an ACL reconstruction. And look, people have done well. We get people back to sports. They're able to get back in 9 months and everyone is happy. But I don't think that's necessarily the case. ACL reconstruction is not a perfect solution. It's replacing rather than restoring the native ligament. And we know that the native ACL has a lot of functions. It has a double bundle morphology. It transitions through a ligament cartilage zone that has proprioceptive, functions and fibers. So there's a lot to be gained for preserving the ligament. It also avoids graft harvest with the associated pain and issues, relating to that. And of course, smaller and fewer incisions. But I think the first point is really the most important. If you can preserve that native ligament and preserve the stability that native ACL gives you, I think it's beneficial. You alluded to animal studies. Martha Murray did an animal study that I always love showing my patients, which was the repair versus reconstruction versus nothing. And they found that though reconstruction did well, there was still some cartilage damage in that animal model versus the repair had none. And so I think that's really appealing when we're talking about a 15 and a 16-year-old, that if we can restore their native ACL and minimize that arthritis, I think that's a win.
Yeah. And I think, we talk about our youngest patients, our, early adolescent type folks. We already know that re-tear rate is really high, no matter, how well we do the procedure, whether it's, hamstring, it's quad, it's patella tendon, it's iliotibial band, they just have a higher risk. And so another thought of why you do this procedure is that you haven't burned a bridge. If this person is most likely to tear at some time later in their life, you haven't taken away one of their graft options. So I personally don't do a lot of pediatric ACLs, but that's what I do hear from the pediatric colleagues. So Dr. Albright, being one of them, that, you're not burning the bridge. So
Absolutely.
let's talk about what actually is the bear. So I alluded to it a little bit briefly, but the bear scaffold, it's basically a decellularized type 1 bovine collagen implant that holds blood, so the patient's blood. The implant so basically it gets implanted at the time of surgery with the patient's whole blood with a repair construct. And there's different ways that surgeons do it, but they're basically repairing the ACL while this collagen implant is being put in. So let's just go a little bit into the data.
Yeah, I think the most important thing, at least that I take away from the data, is that it is at least equivalent to a reconstruction in terms of its laxity, and in terms of the patient-reported scores, the IKDC scores, range of motion, and ability to return to sport. And people may say that's not a win, but I think if you're preserving the ligament with a less invasive procedure, not taking a graft, and you're getting equivalent scores, I think that's really beneficial. And I think there are some studies that show some benefits compared to ACL reconstruction: better hamstring strength at 6, 12, and 24 months. Earlier resolution of symptoms. I think Sean Anthony, which we should mention, you should check out our AOSSM episode on the bear implant with Sean Anthony that we recorded live at AOSSM. And he points out he has to hold patients back. They feel better sooner, and they think that they're ready to go back into play at like 4 months post-op. And you got to tell them, no, it's still 9 months. So kind of protect people, from themselves.
I don't think I told you this one actually, but I had someone come in recently who was about 4.5 months out, and she wanted to go to like a water park, and I was just like, no.
I've been getting that question a lot too. And roller coasters, and I'm just like, what kind of a roller coaster? Are your legs dangling? Like, can I just say no across the board? Like, I don't know what this roller coaster is. It's just, we get that a lot. No.
In New Jersey.
I've heard about it, but I never went. Did you? Because you grew up.
Yeah. So that's what I picture when people want to go to water parks, and I'm like, no.
Oh my gosh. I mean, that'll hurt you even if you haven't had any surgery. So just stay away from that.
So we talked about the difference in data, and basically that last point you were making that I interrupted you is basically they have better psychological readiness to return to sport at an earlier, like they're starting to show those improvements at 6 months, and but the return to sport is exactly the same. So if anything, we have to tell them to cool down. Yeah.
Absolutely, yes. Protect them from themselves.
I do both traditional ACL reconstruction as well as the bear. It's just more one more tool that we have and one more option for patients to choose from. So exciting stuff.
Absolutely. So then let's move on to the next one. So this was not a winner of the ACE Award, but this was one that we listened to intently, and we were all very impressed as judges about this implant. So we do want to talk a little bit more about it, and that is the Smith & Nephew Regeniten implant. So what is it? Let's start with what is it. So the Regeniten implant, it's a resorbable bovine collagen, so from a cow, and it is a bioinductive implant that can be used for repair of partial thickness rotator cuff tears. So unlike other patches, and I use that in quotes because their intent that it is not a patch, it is an inductive implant, and that makes sense because it is different. So this is a porous implant, and it induces the growth of new tendon-like tissue into it, and it actually adds to tendon thickness and can augment repair of rotator cuff. So really appealing. So Catherine, you want to talk about maybe why we would use this implant?
Yeah, so basically indications, why do we use it? So partial thickness tears are approximately twice as common as full thickness tears and can lead to considerable pain and loss of function. So although some of these partial partial thickness tears can be treated non-operatively. Spontaneous healing is unlikely when it's greater than 50%. So non-operative is really unsuccessful with those. So Regeniten is utilized as a repair of partial thickness rotator cuff tears with formal tendon bone reattachment. Because the implant does not require tendon bone reattachment, treatment does not typically entail prolonged rehabilitation.
Absolutely. And that's really the benefit. They say you can move them as soon as like a few days after the surgery, discontinue the sling. I still do 2 weeks, though I'm usually always doing a biceps tenodesis with this procedure. So I'm usually keeping them in sling anyway for 2 weeks, but I'm not that aggressive that I'm just going to get them out in 2 days. But yeah, I mean, when I do this, I do get them moving sooner rather than later. It's much quicker than a standard rotator cuff repair. And I think the data really backs this up. And this is what made me so excited, because I feel like, I don't know about you, Catherine, but I know you deal with a very young population in Colorado. But sometimes I get in there and I'm looking at a partial tear and it's not enough to take down and repair. It's not one that I want to do a pasta and increase stiffness. But it's not one that I feel like I can leave. Like I clean it out and I'm like, I feel like this patient's going to still have pain with lowering their arm and still have some weakness. And now we have this tool, at least I feel like I have this tool to be able to add tissue to the bursal side, offload that area of tear and allow it to heal itself. And patients are doing really well. And this is borne out in the studies. Studies show that doing a repair plus this implant versus the implant alone, equivalent outcomes. Actually, they feel better faster. So I think that's really exciting.
Yeah. And I will add, in that group that you're seeing that's young, that basically you're like, oh, I just don't want to leave this, and it's too small to really take down the tendon fully. I think the other thing I think about when I look at those is, oh my God, they're going to make this so much worse if I don't do something, because they're just going to another like tumble or something. And it's going to go from that 50% to full because, you just have that leading edge and it's already started. So I think, definitely, a good place for this. So yeah, I think, they were really great. Like, I think they've done a lot on their, sort of their lab-based studies and really show that they're doing a great job. They've got great outcomes as far as like all their, kind of histo and lab basic science studies.
Absolutely. Awesome. So thank you so much for listening to our overtime chat today. We hope you enjoyed our conversation. Make sure to subscribe on iTunes, Spotify, wherever you get your podcasts to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review. Also check us out on YouTube to see more diagrams and graphs and things from some of the literature that we reference. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod or at Twitter at thesportsdocpod. No S. We love your feedback.